Akshay Badakere to get ready with the screen. And Dr. Akshay is a pediatric ophthalmologist from Shankar Nethralaya, Chennai. He did his fellowship from LV Prasad and was a consultant there for some time. And we are happy to have him talk on what did I do differently about strabismus in this ASPOS session. Welcome to all the audience. Thank you.
Good evening, and thank you, Sunita ma'am, and thanks everyone for the opportunity. It's great to see everyone online, and especially to meet my close friend, mentor, guide, Dr. Preeti, whom I'm seeing after so long. Really nice to see you, ma'am. So it's a very nicely titled session. What did I do differently in 2022? And I've titled my talk as Not Always Surgery. So through that, I have no financial disclosures. We have obtained consent for clinical photos and videos as well. And we'll go through an illustrative case. We'll look at how screen time can affect the eye and systemically as well. We'll go through what acquired esotropia is, the workup for acquired esotropia, why we choose Botox, and I'll conclude after that. So the story begins with a 7-year-old girl. She was brought in by her parents mainly with double vision and inward deviation since 8 months. On probing a little in detail, it was revealed that she was having exposure to to handheld gadgets for almost 7 hours a day, 4 to 5 hours of coaching sessions every day, and music lessons via smartphone. And apart from that, also some recreational activities for an additional 30 minutes. On examination, she's best corrected visual acuity is 6/6. She's N6 with and without glasses. Cycloplegic refraction was +1. Her stereopsis was 40 seconds apart. Extraocular motility was full and free. Her strabismus evaluation revealed a 35 prism diopters of intermittent esotropia. This was a comitant esotropia, and she had uncrossed diplopia on the red filter test. We looked for cerebellar signs. There were none. Her cranial examination was normal. Anterior and posterior segment were within normal limits. So we came up with a working diagnosis of acute acquired comitant esotropia. Now, this is not something new that we have seen in the post-COVID era. This is a paper by Dr. Nina, which has shown that in her paper, almost 11 subjects were children, and almost all of them had nearly 8 hours of near activity on smartphones and other devices. And she also concluded that exposure to smartphones for so long is a risk for acute acquired esotropia. Apart from this, it can also lead to stress and anxiety, sleep disorders, metabolic issues like obesity, insulin resistance, increased levels of stress hormones, and it can mess up the circadian rhythm. So not just the eye, but the systemic factors is something that we need to keep in mind. Our experience, this is some unpublished data that we have gone through. From March 2018 to Feb 2021, we have had 59 patients of ASE. And what is interesting is the screen time. You can see that pre-COVID, the screen time maximum was 2 hours in the 2 to 3 hours range. And this has almost tripled in the COVID era and the post-COVID era. This has led to an epidemic of esotropia. Now, if you look at a simple PubMed search, will show you a lot of articles on the effect of digital eye strain on the eyes of children. Now, what is acquired esotropia? It's a relatively rare and distinct subtype of esotropia. It's a non-accommodative deviation. It can result in 2 ways. One, it can result from a deterioration of a pre-existing well-controlled esophoria, or it can present acutely as an esotropia with diplopia, which we call as AAC, and it contributes to about 0.3% of childhood strabismus. There are 5 subtypes. Type 1 occurs after a period of interrupted binocularity, typically seen in children after a period of patching. Type 2 is known as the Burian-Franceschetti type, which has very minimal hypermetropia, but normally some physical or psychological stress leads to esotropia. Type 3 is the Bilchowski type, seen in myopes. Type 4 is the refractive accommodative type, and probably this is the easiest to correct. Good cycloplegic refraction and glasses take care of the squint. And type 5 is associated with posterior fossa lesions and intracranial pathologies. So coming back to our case, we asked for the old photos and it confirmed what the parents were saying. We got an MRI brain done, which was normal. We also did an orthoptics workup and atropine refraction. We tried a prism trial. The child was not comfortable with prisms. So the next option that we had was either surgery or Botox. Now, Botox is not something new in ophthalmology and in strabismus. It's been used for quite some time. And if we go through literature, the consensus among people using Botox is that one, it is convenient, it needs very little time. It's a simple technique, whether we do the transconjunctival technique or the open sky technique, it's very simple. Learning curve is not steep at all, very minimally traumatic. It is cost effective and the outcomes actually are quite similar to surgery. So in our case, we gave 3.5 international units Botox to medial rectus bilaterally. We also advised the parents about the importance of reducing the child's screen time. This child was using screens for almost 7 hours a day, and lifestyle changes also were advised. In a short surgical video of the procedure, a small fornix incision is made. Then we hook the muscle. Then with a small hook, we actually just tent up the conjunctiva to get to expose the muscle nicely. And using a 30 gauge needle, about 4 millimeters behind insertion into the muscle belly under visualization, the Botox injection is administered. We also must take care to ensure that there's no spillage of the injection after it is completed. So this is the result at 4 months. You can see well-aligned eyes. Child is actually, we have advised her not to use glasses because she is doing well without her glasses as well. And my personal experience is that I have administered now 12 cases of Botox in AACE. The median age is about 8.7 years. You can see the deviation ranges from 16 to 45 prism diopters. I use an open sky technique. One case had residual esotropia, but this patient is doing well with prisms. The follow-up period is short, mainly because these are outstation patients and sometimes follow-up can get missed. But those who have come, they are doing well up to almost 4 months post-follow-up. One child had ptosis. This is a known side effect in Botox, and typically it resolves within about maximum 3 months. In this child, it resolved in 2 weeks. So I think for AAC, what is important is a complete good history taking. We need to probe into what could have possibly led to the esotropia. Our ophthalmic examination should also be very thorough. Atropine refraction, orthoptics where needed. Neurologic exam in the OPD can be done in a very simple manner. Just the Romberg sign and looking for the finger to nose test give us clues about any central nervous system involvement. Cranial nerve examination also helps. And I think AAC, we should look at it as a diagnosis of exclusion. So we should do an MRI brain, make sure that there is no CNS pathology, and then go ahead and do give the treatment. So I would conclude by saying that AAC requires a complete ophthalmic basic neurologic workup. Do not hesitate to image. Lifestyle changes and education. Education not just of parents and the patient, but I think even in public forum, educating schools that while screen devices and these gadgets are fancy, they may not be the best option for our kids. And Botox is definitely a viable option. With that, I would like to conclude. Thank you for the opportunity and for the patient listening. Thanks a lot.